Hello, my name is Daniela Edson, and welcome to my DNP project, Pain Management in Adult Trauma Patients. I was assisted in this project by Dr. Woya Gia-Sadine, collaborating statistician, Dr. Aaron Rose, my DNP faculty, Dr. Justin Koenig, my DNP preceptor, and Melinda Dubner, hospital pharmacist. Pain management is considered the fifth vital sign in the care of patients. Ensuring that patients have adequate pain control is key to their healing. The overprescribing of opioids has led to a devastating opioid crisis that requires providers to be aware of how many opioids are available to the patient. It is reported that less than 50% of providers can accurately assess a patient's analgesic requirements. Evidence has shown that by prescribing a scheduled multimodal pain regime, trauma patients are provided more consistent pain control while decreasing overall opioid use. South Bend, Indiana area known as Michiana has a 23.8% poverty rate. The significance of the poverty rate is important because statistics have shown that those patients of a lower socioeconomic status experience more blunt and penetrating trauma. The setting is a 400-bed acute care community level 2 trauma center and children's hospital located in northwestern Indiana. It is the highest level trauma center for a 90-mile radius, which serves northwest Indiana and southwest Michigan. This is important because patients are transported to the nearest trauma center to receive care. The emergency room sees a reported high volume of 40 to 60,000 patients per year. The location of the hospital creates an increase in patients that are traveling as it is located on the 80-90 interstate and has many universities in close proximities, such as the University of Notre Dame. Currently, no guidelines or standardization of pain medications is provided to admitted trauma patients. And prior to this project, there was no guideline or policy that guided providers on the prescribing of pain medications, which led to wide variations and at sometimes no pain medications at all. The project aim is to reduce the overall narcotic use for inpatient adult trauma patients within 3 months of post-implementation of the project. Ensure that 90% of adult patients admitted for trauma and orthotrauma have scheduled non-opioid pain medications such as Tylenol on their medication profile post-implementation of the project. Along with non-opioid medications, the trauma and orthotrauma population have non-medication alternatives such as ice and elevation scheduled and that they become part of the patient's treatment plan. The last goal is to decrease overall PRN opioid usage by 25% within 3 months post-implementation of the project. When looking at the methodology of this project, participants were those patients greater than 18 years of age, even if they were admitted in the Children's Hospital, admitted to the hospital for trauma or orthopedic trauma, and were admitted for greater than 23 hours. Exclusion criteria were patients admitted to the ICU at any time during their hospital stay, if they had neuro or spinal cord trauma, if they had use of a patient-controlled analgesia or PCA, pregnancy, and those patients who left the hospital against medical advice. The tool that was utilized was the numerical pain scale, which is a highly validated tool utilized by the nursing staff to quantify the patient's subjective report of pain. The retrospective portion of this study started March 1st, 2020 through August 1st, 2020. And the implementation time began January 1st, 2021 and went through April 10th, 2021. The data collection was done with the trauma registrars providing a list of patients that were admitted on medical or surgical floors and were greater than 18 years of age. This list was provided through the encrypted hospital email system. Charts were then reviewed for inclusion and exclusion criteria. The nursing staff is prompted by the EMR to enter a numerical value for the patient's reported pain prior to medication administration, which was part of the data collection. A data collection sheet was utilized to document age, gender, injury severity score, injuries, scheduled pain medications, PRN pain medications, and the strength of medication. This data collection sheet was kept within a locked file cabinet that was only accessible by one person. SPSS was utilized and data was manually entered. Outcome data was from retrospective and prospective chart review data. When looking at the retrospective results, 512 charts were identified by the trauma registrars. 105 patients met inclusion criteria. Of these 105 patients, 4 only received weak medications such as Tylenol and were excluded from the final data analysis. An independent t-test was performed to investigate any significant relationship between the change in pain perception using standardized versus PRN pain treatment. The results did not show a significant difference, with a p-value equaling 0.432. To investigate the overall effect of prescribed medications on the perception of pain, a paired t-test was performed. The results identified that there was a significant reduction in perceived pain for those patients after receiving pain medications. P-value was less than 0.0005. Looking at the bar graph that is available, of the 105 patients that were identified, 46.7% of them received a scheduled pain medication regime. Continuing to look at the retrospective results, an independent t-test was conducted and identified there was no significant difference in the perception of pain and the strength of the opioid medication, moderate versus strong. To investigate any positive relationship between injury severity and perception of reduction of pain after receiving their treatment, a Pearson correlation analysis was performed and showed a very low significant positive correlation between injury severity score and perception of pain. The pie chart available has a percentage breakdown of the 105 patients that were in the included retrospective analysis and the percentage of which kind of pain medication they received. 3.8% only received weak PRN medications. 24.8% received a moderate PRN medication, and 71.4% received strong PRN medications. Post-implementation analysis began January 1st, 2021. Currently, there have been 23 patients identified that fulfill the inclusion criteria. Of the 23 patients, 78.3% have a scheduled multimodal pain regime in their treatment plan. Proportionally to the retrospective analysis, this is a 68.2% increase in patients who have received a scheduled multimodal pain regime. An independent t-test was performed which compared the change in perception of pain of standard versus PRN pain treatment. The results were consistent with pre-implementation and identified there was no statistical significance in patients' perception of pain with only PRN medications. Out of the 23 patients, the bar chart shows that 78.3% received their multimodal pain regime. The opioid epidemic in the United States has led clinicians to investigate different approaches to pain management. Evidence-based research has identified that through the use of a standardized multimodal pain regime, patients achieve adequate pain control while minimizing overall opioid use. This project builds on recent literature that supports the use of a multimodal pain regime. The retrospective analysis identified there is no statistical significance in the perception of pain for patients who received a scheduled multimodal pain regime with minimal PRN pain medications to those patients who received only multiple PRN opioid pain medications. In conclusion, the implementation of this project, while ongoing, has supported through the use of a multimodal pain regime that uses scheduled non-opioid pain medications such as Tylenol, non-medication alternatives such as ice and elevation, and minimal PRN opioid medications. Patients are provided consistent pain control while decreasing overall opioid requirements. This project leads to the recommendation of establishing a protocol that provides adult trauma patients with a scheduled multimodal pain regime. Evidence-based literature identifies that patients with adequate pain control during their hospitalization will have overall better outcomes and will successfully discharge from the hospital without unwarranted delays. Thank you for your time and attention. Included are a key list of references that were instrumental in guiding this project. Have a great day and stay safe.